Thanks, Ashley. Thanks, everyone, for coming. So I chose focal therapy, obviously, because it's a project I'm involved with currently, but it's also a very controversial topic. And a lot of the editorials have been written in the literature, pro and cons, and even at some of the conferences, some of the big names are taking pro and con stances. So it's a nice topic to review. And I think we're in an era where we're going to be revisiting focal therapy in a real way. So the objectives then are predominantly to discuss the background and the rationale for focal therapy, because before we can design a trial and discuss about different technologies to deliver focal therapy, we have to have a strong rationale for it. And there's a lot of controversy here, specifically with regards to the prostate pathology, being multifocal, for example, and imaging of whether we can actually target a specific lesion within the gland. And so I'd like to review that first and then move on to how to design a trial to study focal therapy, and then discuss new technologies for focal therapy, including one that I've been working on in the lab, which is a polymeric biocompatible paste, which could be injected under imaging guidance into a tumor. So first off, right off the bat, focal therapy is attractive, especially for patients. Again, in the literature, these words come up all the time of having a male lumpectomy and having a manogram to surveil the prostate instead of repeated biopsies. And this idea that's come out that tissue preservation equals functional preservation, which isn't necessarily true or proven, but this is the understanding that a lot of patients have when they hear about some type of focal approach to the prostate. So we have to keep that in mind from a patient point of view, but obviously study these things to see if it really holds true. So again, talking 2015, where we are and how we're moving forward, there's a lot of renewed interest in focal therapy in prostate, first of all, given outcomes in other organs, specifically for this audience, kidney. And a better understanding of the natural history of prostate cancer is really exemplified in the acceptance of active surveillance currently, the idea of insignificant prostate cancer, and the idea of this index lesion, which we'll review in some detail. We have better imaging of the prostate gland, especially with multiparametric MRI. We can fairly confidently determine tumor size and allow certain mapping and targeting modalities to really target what we're seeing on a screen, which is an exciting approach to target things within the prostate. And again, we have better technologies to deliver tissue destruction in a focal zone within the prostate. So really, it's the coming together of these three factors which might reopen a niche for focal therapy. And I say reopen because it's been going on. Focal therapy has been done at different sites over the past 20 years, I'd say, but again, the quality of the evidence that's coming out of that hasn't been enough to really move clinical practice.
How many centers are active?
I don't know what you mean by aggressive, Dr. Sullivan, but
say that they're doing a third of the patients.
There's several centers in the U.S. There's several centers in the U.K. predominantly. A few authors all come from one center. I don't exactly know the name of the center, but it's within the U.K. I think it's in London as well. Yes, and Dr. Ahmed there. So there are a few centers that are really moving it forward, but again, from what's been described, it's all small retrospective series. So, So here we are, prostate cancer is being substratified to many different risk categories. Even intermediate risk, Gleason 7, is now appreciated as 4+3 and 3+4, which is an important distinction. But the spectrum of treatment ranges from active surveillance to radical prostatectomy, and there's radiation therapy somewhere on there as well, depending on the life expectancy of the patient and obviously the disease state. But the question is whether focal therapy could have a renewed role, either as an adjunct to active surveillance, helping spare additional men from radical prostatectomy. It's important to stress, though, that radical prostatectomy should not be excluded because of a focal therapy modality that's been undertaken, whereas radical prostatectomy was delivered quite indiscriminately earlier on. We're now appreciating the different risk stratifications of prostate cancer and reserving radical prostatectomy for the highest risk. Active surveillance for those that have very slow, non-progressive type prostate cancers. And again, that niche for focal therapy as an adjunct active surveillance remains open, especially when we don't exclude a radical prostatectomy. And that's not to say that the radical prostatectomy should be a salvage prostatectomy, but should still be a relatively straightforward operation. And this is just a small series from the Toronto group where they do quite a bit of private HIFU. Just a small series they published on the difficulty of the cases going to a radical prostatectomy post-HIFU. These are all gentlemen that would have what's called low risk or low intermediate risk, and they're having 100% ED at 1 year when they eventually need an RP. From the radiation perspective, radiation might be less effective in hyperperfused and scarred tissues that can occur after focal therapy. So again, these are some of the classic barriers to delivering focal therapy in a meaningful way. And so to stress that any radical prostatectomy post-focal therapy ideally should not be a salvage procedure. Now, the common reasons against focal therapy, and these I'd like to go over in some more detail, is again, prostate cancer is multifocal. It doesn't make sense to target one individual lesion within the background of cancer in the gland, and we're unable to localize prostate cancer. The last point is also brought up quite a bit of whether focal therapy really plays a niche, but I think that given our understanding of the natural history of prostate cancer, one could argue that there's usually a patient niche for focal therapy. So from the pathological standpoint, there's a few points to review. First of all, is what is insignificant prostate cancer. This, unfortunately, is the cancer that's treated by a lot of focal therapy modalities in the paper, so it needs to be defined, and ideally this is not what we want to treat with focal therapy. And then review the index lesion and the idea of multifocality. And a take-home point, a lot of the papers on this topic stress is that we're now risk stratifying patients based on individual lesions as opposed to the whole gland, because in this type of approach, there is no radical prostatectomy taking place. The first is insignificant prostate cancer. This is what we do not want to treat with focal therapy or radical prostatectomy. It's very amenable to active surveillance. It's very, very low-risk disease, typically defined as organ-confined Gleason 6 and very low volume and few cores. The idea of insignificant prostate cancer has come out from a lot of population-based studies, looking specifically at outcomes of patients with pure Gleason 6. And so this is a large cohort, American cohort, and you see the 15-year prostate cancer mortality was 7% in the entire cohort, but in those with specifically organ-confined Gleason 6, it's very, very few. And the way that they quote this to patients then is that if you're under 60 years with pure Gleason 6 organ confined, there's a 1.2% prostate cancer specific mortality at 20 years. The mortality is very low, and this has decreased the enthusiasm for treating Gleason 6, which obviously can be followed readily with active surveillance.
The problem with that is that that's made on
Exactly, and we'll touch on that as well, but certainly higher volume disease, you risk of missing some occult focus of higher grade disease, and so volume is an important consideration here, but in this paper, they're just taking all-comer Gleason 6 regardless of volume, and the mortality is still quite low. Now that volume threshold of having it under 0.5 ml has been looked at as well, and these authors again took organ-confined Gleason 6 disease and played around with the threshold volume for what would be considered insignificant disease, and then looked at outcomes like prostate cancer-specific mortality, but specifically biochemical recurrence. And what they showed is that when you increase that threshold volume to call, let's say, 2 ml focus of Gleason 6 insignificant, there's actually a much higher biochemical recurrence rate, and even some prostate cancer deaths that are then seen. And again, the assumption is that these don't reflect pure Gleason 6 disease, but the higher volume you have, the higher chance you have of missing microfoci of higher grade disease. And this bears out in the Kaplan-Meier curves that the higher grade Gleason 6 have a significantly higher biochemical recurrence at 10 years. And so this, I don't think, can be defined as an insignificant disease. This is something we would really like to avoid. Now, the idea of the index lesion has come out in a lot of papers over the past few years, and it's a pathological description stating that the largest lesion on the radical prostatectomy specimen is typically the lesion that contains the highest grade stage and is the tumor burden that's responsible for progression, metastasis, and eventually death. It'd be great if that was true, and it doesn't seem to always be the case. And from a targeting point of view for focal therapy, we want this to be distant from important structures. So a few theories that have looked over this This was a series of 100 consecutive radical prostatectomies, and they're asking, based on these criteria for focal therapy being either unifocal, organ confined, 3+4 or less, or multifocal where the secondary foci are what's considered insignificant disease, of these 100 consecutive prostates, the authors conclude that over 50 could be suitable for a focal therapy approach based on this idea of the index lesion. And this would just be what we're seeing from a pathological point of view. The upper image is a tumor where the dominant foci, there are separate foci on the other side, but again, it's low volume, low risk disease. And so is this something where we can safely treat that index lesion and leave the rest of the gland, versus the bottom picture where the contralateral focus is high risk disease where you would want to know about it and treat it. Another series of 100 consecutive RPs, just underlying the multifocality of prostate cancer. This comes across in multiple series, 70–80% multifocality and over 3 sites of tumor per gland. But in this series, there was no case where the secondary lesion harbored findings that were worse than the index lesion. So again, this supported the idea that that the index lesion might be that dominant lesion that results in progression, medicine death. Another series that came out with slightly different findings in this series of 200 consecutive prostates highlighted the fact that in 12.4% of the time they had a situation where the secondary lesion did harbor either higher volume or higher grade disease or even extracapsular extension versus the index lesion. The argument here, and this article has been cited a few times in the focal therapy world, is that with the use of MRI to exclude non-organ confined disease, you're only catching these PT2, that first line where the secondary lesion has worse characteristics. And most of the time, it's rare that it is larger. Only 6.5% of the time was there a larger volume contralateral disease. The idea of the index lesion also comes from these types of papers where several persons had warm autopsies done on their metastatic deposits with known metastatic prostate cancer. And then they sequenced all the different sites in these patients by different methods, either copy number analysis, to try to determine the clonal origin of each of these cells. And the authors conclude that there is monoclonal origin of all these metastases that were viewed from almost all patients. So the way they cluster each metastatic site that they sequence, you can see most patients represented by the different colors and symbols all cluster together. There are some patients that do not, so there were some where it appeared that the origin of the metastases were quite disparate, but most of them did come down to a original clone. And so the model that is proposed then is that within a multifocal prostate with multiple tumors, there's only one, ideally the index lesion, that bears that ability to metastasize either to a lymph node and then beyond, or from the prostate directly to metastatic deposits. This paper unfortunately didn't mention the Gleason score of the original prostate lesions, which would have been helpful. Next slide. Oh, sorry. There we are. So this is one of the PIs from the hospital in London, who is really a proponent of focal therapy. And so he wrote an article in New England stating that if the index lesion hypothesis is true, and it is that these clonal cells that give rise to the metastatic state, then the targeting the index lesion doesn't make sense, and that clinical trials in this space are warranted. So this is where we are now from a pathologic point of view. But the debate continues. It's not hard to find papers that contradict the idea of the index lesion, or another one that also tracks the origin of metastatic prostate cancer in one single patient, not that large number we saw before. And they concluded, based on sequencing of the metastatic site and looking back at the patient's RP from 17 years prior, that the clonal origin that resulted in metastatic disease in this one patient was a 3-millimeter focus of Gleason 6, what people would consider insignificant. And this, again, is quoted quite a bit as a reason why that index lesion hypothesis is not necessarily true. So there is a lot of debate that remains there. Now, from an imaging and targeting point of view, can we target that index lesion if we want to move forward with an approach to focal therapy? So the questions here are whether a biopsy can give a specimen that's representative of what's going on in the whole gland, which is the ideal situation, and whether multiparametric MRI can actually bring this type of resolution of the prostate. And certainly, focal therapies today are almost always using MPMRI as an imaging and targeting approach. Now, without the radical prostatectomy, MRI now has to be compared against other histopathologic variables when we don't have the prostate. And so that includes either saturation scheme biopsy, which is random, transperineal template mapping biopsy, which is a very systematic approach to sequencing targeting the entire gland, and then actual targeted biopsies based on image-guided modalities. This is the way that prostate is being viewed nowadays, especially from a radiology point of view, and Dr. Tempany gave a nice talk on this, so I don't want to highlight it too much, but the way these transperineal mapping biopsies are subdividing the gland into 20 or 30 anatomic zones, taking a biopsy of each of these sites systematically along a 3 millimeter or 5 millimeter grid to really try to sample the pathology of the entire gland, and then these devices somewhat but integrated with the MR to really allow accurate targeting multiple times of a specific site. So if this is really true, if we can do this, then it really increases the ability of to deliver focal therapy to these lesions. So here, this is one of the reasons why just standard 12-core random biopsies is out. These are patients that underwent radical prostatectomy based on the 12-core biopsy findings, and these patients had unilateral prostate cancer on the 12-core biopsy. But still, despite them having this 12-core standard biopsy, 40% of the missed tumors were clinically significant. Yeah, so even by random biopsy and 12-core, which would be considered kind of standard of care, many clinically significant diseases are still being missed. The transperineal mapping biopsy is a nice way to survey the whole gland, but it's difficult because it requires time, general anesthesia, and much more patient discomfort when they're getting hundreds of biopsies taken. But you can see the type of resolution that it gives of showing where the tumor is specifically located within the gland, also to guide focal therapy. In this study here of 25 patients that underwent both radical prostatectomy and a mapping biopsy prior, only one clinically significant cancer focus was missed. Several other posts that were missed as well. But these are all clinically insignificant disease, which one would argue we don't want to identify as readily. But it really comes down to multiparametric MRI, and it's important to stress the three phases that are used to evaluate the prostate, and that's T2 weighted for anatomy, dynamic contrast enhancement to look at vascularity, and diffusion weighted imaging, which is used to deliver this ADC score, the apparent diffusion coefficient score, which is a reflection of cellular density, and it appears is also a reflection of the Gleason score, because that reflects architecture from a histology point of view. This is one of the big papers that came out this year in JAMA, so really trying to address public health concerns related to prostate cancer screening and identification, but just showing that the same number of cancers are diagnosed regardless of MRI versus a standard random approach, but the nature of the disease you're finding is much different. The MRI is finding much more high and intermediate risk disease that you want to do something about, and whereas the standard approach, we all know, identifies more low risk and insignificant disease. Of these 1,000 patients, 170 went on to prostatectomy, and then based on the RP pathology, they looked at, I'm not sure what I'm doing here that results in that, but they looked at the ability of MR versus the standard biopsy risk stratification of the patients, and they found that the targeted approach is much more accurate to risk stratify patients. It's not perfect, though. You can see here on the top right of the screen, there are cases where the targeted biopsy suggests that there's no disease, and the random biopsy does find high-risk disease, but there's much higher number of patients where the biopsy suggests no disease or low-grade disease, and the MR suggests that there is high-risk disease, which does end up being the case on the radical prostatectomy. Now, the ADC score, Dr. Tempany spoke about it quite a bit when she came here, so I even borrowed some of her slides with her permission on this. But these classic box plot curves that we see a lot of now correlating different Gleason scores with the ADC value, showing that even from a non-invasive MRI, a lesion can can start to be characterized in terms of its Gleason score, which really helps us, without even touching the patient, identify the risks within the prostate gland. And this is still being worked out currently, but this is one recent paper that came out. They're trying to optimize the ADC. So here's the results of the ADC map, and what they're doing here is taking the ratio of the benign area to the suspicious area to see if that gives a better reflection of Gleason score versus just the raw ADC score alone. So there's a lot of ways to manipulate this parameter to optimize its characteristics to correlate it with Gleason score. And you can see here that the focus that was identified, the patient ended up having a radical prostatectomy, and they identified the disease they expected to see based on the MT-MRI. So there have been meta-analyses and systematic reviews that have come out on this topic. They're a little bit poor because of the nature of the underlying studies. There's quite a bit of heterogeneity with regards to what the reference standard was, whether it was an RP or just a random biopsy or some type of mapping system. And then a lot of the MR technical parameters of whether coils were used and all that. I didn't want to get into that, but that has been discussed by Dr. Tempany earlier, and what was the criteria for clinically significant disease. But in this review, they were able to find 12 studies that had a decent number of patients and used full MT-MRI to identify clinically significant disease. And while the accuracy does vary quite a bit, with the newer series having higher accuracy, the negative predictive value of MRI is consistently high, and this is one of Dr. Tempany's take-home points, that MRI is getting quite good at ruling out clinically significant disease. So the benefits then are fewer false negatives, better gland characterization, even with regards to location of sphincter, nerves, etc. So it can even help for operative planning. There's a higher yield of clinically significant disease, and as we said, a high negative predictive value. And so MR is likely to serve as and already is serving as an adjunct active surveillance to help select patients that require additional therapy. And could that additional therapy be a focal therapy approach? That's exactly right. Yeah, that's exactly right. And then as we discussed, high volume Gleason 6, which you want to capture, might be missed just on MT-MRI. The combination is likely going to be some type of random biopsy with MT-MRI targeted biopsies on top of that. That's a very good point. They have. I didn't include it because there's two of these meta-analyses that came out about the same time that had quite different numbers, so I didn't know where the truth actually lies. Yeah, with MT-MRI targeting, we essentially hear that we're getting a much higher yield of clinically significant disease versus the... Yeah. And so these are a few slides from Dr. Tempany's talk, just giving the classic example of a patient on active surveillance receives a repeat MRI for a bump in the PSA, and there's a clear change on imaging, and these are the ADC maps showing that dark region suggestive of a higher grade disease. And so the MR report then states that the lesions increased in size, decreased ADC value, and so some type of confirmation is required. The patient then went on to have a targeted biopsy, which showed increased grade of disease and increased volume as well. And the patient went on to prostatectomy. And the question is whether a patient like this might also be served by a focal therapy approach, if indeed they have localized 3+4 cancer, and the remainder of the gland can be clear or just have clinically insignificant disease. This is another one of her slides just showing how integrated their setup is, that their OR has MT-MRI and PET-CT established within it. So what they can do in their OR suite is really something, and a lot of their results are exciting. So there is a need to fuse those MR images with ultrasound to bring this to the clinic and to disseminate it more widely. And there are limitations here as well, just with regards to the gland swelling, prostate gland moves with breathing, etc. And so, the technologies to target something that's seen previously on an MRI are coming. And I don't know if anyone here has any experience with any of these. This is just one random system that superimposes the MR image onto an ultrasound. So that was a review of some of the pathologic and imaging concerns. And so if we do want to move forward then with a clinical trial in focal therapy, how can that best be achieved? So we come back to the standard questions here. What does focal therapy mean? How are we going to design it? How to select the appropriate patients? And what is a successful outcome in this space? And a lot of controversy resides as to the approach to focal therapy and whether it's one of these ultrafocal approaches, hemi-gland ablation, or a hockey stick pattern targeting multiple foci, if there are. So there is a prostate cancer RCT working group, and many of the authors were part of this paper, suggesting some of the outlines for what would constitute inclusion criteria for a focal therapy trial. As you can see here, they did include Gleason 3+3 as long as the biopsy showed substantial cancer, but that wasn't quantified any further. But 3+4 would certainly also be included, but to stress here that it's patients with clinically significant disease. They really want to move away from including patients that have what we all would identify as insignificant cancer. And the exclusion criteria are what would be expected, essentially any previous treatment. The pre-treatment assessment would include PSA, but PSA is not followed as a hard endpoint, but we must follow it along any of these studies. And that trust biopsy alone is now insufficient for identifying candidates for focal therapy. There needs to be some type of imaging modality as well, or a more systematic approach. Some authors do advocate for that template approach to sample the entire prostate gland, whereas more commonly it seems to be a combination of either template or random biopsy with then MR-guided biopsy on top of that for suspicious targets. And again, there's a need to really bring consensus to the way MRs are being reported. And 4+3 should be excluded. That's too high-risk disease and typically should be treated by radical prostatectomy itself. There is controversy on that as well. Primary endpoint is also an issue of contention because the natural history of this type of prostate cancer is on the 5, 10, and beyond year time frame. And so a lot of these studies have as their primary endpoint a negative biopsy at 1 year, which isn't considered adequate enough. So that is what the authors here are saying, that certainly we'd like to see a repeat biopsy in the area that was targeted, showing that there's no residual disease. But again, a lot more consensus is required as to how the MR should document a specific region, specifically to retarget that lesion over time. And PSA is followed, but is not a hard endpoint. So the optimal biopsy strategy, as you had mentioned, Dr. Goldenberg, the authors state that having a trust systematic biopsy and then additional MR-guided imaging probably gives the best representation of what's going on in the gland. But given that, a lot of debate now is around the nature of these tissue cores that are achieved and how best to interpret them. And so this is another area where a lot of consensus needs to be reached, specifically with how to report things like this, where the cancer in red is either 2 foci or 1 longer foci, but they might be reported at equal length. And the question is whether that represents equal underlying disease is unclear. And all authors agree that within a focal therapy trial, one-time retreatment of a suspicious area should be acceptable, as this is one of the advantages of focal therapy. Treatment failure is defined 2 ways. There's in-field failure, where in the region that's been treated, you see persistent or higher grade disease. And then there's selection failure, where these criteria are seen out of the treated field. And it's important to separate those two to get a clear understanding of what the outcomes from the actual focal approach are. And the timeline should be long, probably even longer than what they're suggesting here, to capture that natural history of low and low intermediate risk prostate cancer. And sub-analysis can be done based on PSA, age, etc. The authors came out with another paper in Nature Reviews reiterating some of the same things, but that trust biopsy is inadequate. They want to treat clinically significant disease, and that the control arm in these studies should be standard of care, either radical prostatectomy or radiation therapy. And the outcome might be the rates of local and systemic salvage therapy in some longer time frames. And so the classic approach might be to have patients fit the inclusion criteria and then randomize to focal therapy versus whole gland therapy. And there's other options that have been discussed as well, including patient-based cohorts where patients select themselves based on their quality of life and other functional outcomes, and different cohorts that can be embedded within an RCT framework. And so this is what seems to be coming down the pipeline. And one example of this is the index study, which is looking at HIFU, but specifically in what they're hoping for is in patients with clinically significant disease, as a lot of the problems in this space, again, have been that these reports are publishing on patients that have clearly insignificant disease. And this paper here does have a pathological outcome as its primary outcome, and then secondary outcomes being the quality of life scores, whereas normally it's flipped. And this is a protocol in practice now that the approach for HIFU can either be ultrafocal or hemiablative, or it can even be this hockey stick pattern, and it's dependent on the nature of the biopsy and the provider. Yes, yeah. And that was 2013, and I haven't seen it report anything else other than one thing I'll have here. So I just wanted to highlight then some of the current strategies for focal therapy, and then introduce a new approach that we're proposing here. There's many different approaches to focal therapy, and it's based on the technologies that are available, and so it's constantly increasing and getting better. Again, there's many technologies familiar to us: the thermal, radio, frequency ablation, HIFU, even brachytherapy, which has been validated for the whole gland, has now been delivered in a focal approach, which is attractive because brachytherapy itself is widely available. And then we have a novel method, which is a polymeric paste, which I'll get into. And the papers in this space, unfortunately, are poor, so I don't want to go over them in too much detail, but they're usually small, retrospective, and the primary outcome in a lot of these papers are functional outcomes, not pathologic outcomes. So just comparing some of the different therapies, ones that we might not be familiar with are things like irreversible electroporation, where pores are introduced into the cell membrane to achieve tissue destruction. And then there's focal brachy, for example. And then I'd like to introduce a method of delivering drugs that have already been validated for systemic treatment of prostate cancer within the prostate itself for a local focal treatment. So these are the types of papers that come up, and you know, they're unfortunately not the highest quality, I'd say. But this is a paper from 2012, for example, where they targeted lesions based on ultrasound alone and only did a sextant biopsy, so not even a 12-core. So, you know, you can argue who knows what they're missing elsewhere in the gland. But the approach was to use cryotherapy in a focal approach. 48 of 70 patients, they were able to do it. And in the follow-up biopsy, which was 12 months or 18 months post, the patients that did undergo repeat biopsy, the majority were negative in the treated lobe. Only one was positive. This patient actually went on to ADT, and they don't explain whether he had systemic occurrences as well. A classic curve that these papers present are the PSA responses, which is hard to gauge the value of because the PSA will drop, but should one expect it to have a nadir based on the amount of gland that was ablated is a little bit unclear. This was a recent paper that came out just showing safety of these new technologies, but no pathologic outcomes at all. At least these papers are including more intermediate risk patients, so not the classic cohort of low volume Gleason 6, but their only outcome was functional outcomes at 6 months, and they just state no adverse reaction. And then they compare specifically to radical prostatectomy cohorts showing that at 6 months they have 100% continence, whereas our PE cohorts have obviously much less, and potency is high as well. And so a lot of these papers conclude versus radical prostatectomy, but obviously they're not very well designed to make those conclusions, I think. This is one of an earlier study that's come out looking at low-dose focal brachytherapy. Brachy's been modified quite a bit in the way it's been delivered for prostate cancer, and low-dose brachytherapy is used quite commonly. And this approach allows focal approach to brachytherapy. And so this paper, unfortunately, they do include some clinically significant disease, but the majority of their patients had 1 or 2 cores of Gleason 6 disease. So again, the argument that it's not treating the ideal patient cohort. But in the 14 patients that were treated with focal brachy, only 6 agreed to have a repeat biopsy at 2 years, of which the majority were negative. So again, the conclusions can be far-reaching from papers like this, but shouldn't be. This was one that looked at HIFU in a prospective sense and had the highest number of intermediate risk patients. But again, the primary outcome of this paper was functional parameters at 1 year. And a lot of these graphs are being produced, like the top left, that have the pad-free rate, leak-free rate, and erections quantified over time, showing the initial hits they take post-focal approach, and then the resolution over time. The authors argue is better than radical prostatectomy. It's very, very controversial. And this is an example of the types of failures that we see. The in-field failures of the upstaging in the region that was sampled, only one of 18, versus selection failure of patients that had disease elsewhere in the gland. Here, there was a patient that on repeat biopsy was found to have 4.4 in the contralateral lobe. And so this is someone you'd want to catch earlier on, not obviously later on in the focal therapy trial. That. And so finally, I'd just like to introduce another approach for focal therapy, which is a novel polymeric biocompatible paste. Now, the attractiveness of the paste is that, as you'll see, we're using drugs that have been already used in prostate cancer, and where they're known to be highly active and synergistic. Ideally, by delivering these locally within the prostate, we're avoiding the systemic toxicity associated with these drugs. And again, this paste allows a depot injection with the release of these drugs over time. And it's attractive because it's something that's repeatable, like other focal therapy approaches, biocompatible and cost-effective. And the hope is that it does not exclude or make an RP exceedingly difficult after injection. And we received a Cuauhtemoc Award to investigate this further. The biocompatible paste itself is a polymer of polyethylene glycol and PLGA, which there's a lot of physical chemistry that goes into this, but they're combined in different ratios under different settings to achieve a paste that has the ideal physical characteristics for intratumoral, transrectal, or transperineal injection. And so that's it ends up having a viscosity something like honey, and it forms a semi-solid implant in vivo, which then degrades slowly over time via hydrolysis. And the drug is released in 2 phases, initial burst release and then a continued release as this polymer is being degraded in situ. The cocktail for this paste is a combination of enzalutamide, taxane, which is docetaxel, and a drug called BPC-27. And just the rationale for these is that these are a highly synergistic drug cocktail that has been shown to result in effective cell death. Now, BPC-27 is a small molecule inhibitor of HSP-27, which we know is highly upregulated in response to cell stress. And so in the classic model here of the AR translocating to the nucleus, under conditions of stress, HSP-27, one of the molecular chaperones, is highly upregulated. Let's find them out. But it's highly upregulated and stabilizes the AR to shuttle it to the nucleus. And HSP-27 has been successfully inhibited via the antisense oligonucleotide OGX-427 for quite some time now. And now BPC-27 has been identified as a small molecule which does the same and other functions as well to help prevent the AR from reaching the nucleus. So it would theoretically synergize with the anti-AR approaches, but it also synergizes very well with taxane. So this is using a classic prostate cancer cell line which has been derived to be taxane resistant. And so at classic doses of taxane, the amount of cell death achieved is quite low. You have to go to quite a high dose to achieve cell death. BPC-27 itself is also toxic at log-fold higher concentrations. But the combination of the two results in cell death at even low concentrations. So it synergizes very well with taxane. And this is showing it again in an in vivo model, showing that the tumor growth is highly attenuated in the combo, whereas agents themselves do not result in attenuation of tumor growth in a taxane-resistant system. Just to touch on briefly, this is the recent outcome of the CHARTED study showing that combination hormonal therapy has an advantage, a survival advantage versus providing ADT alone. The caveat being that in this study, the benefit was seen in patients that had diffuse metastatic disease, and there's no real benefit seen in the oligometastatic arm, and obviously we're bringing this to the local prostate cancer arm, so whether a conclusion like this can be taken there is unclear, but I think it underlines the idea of the benefit of combination versus sequential therapy, and so there is a rationale to deliver these agents synergistically.
artist is underpowered to
Mm-hmm.
look at it in the volume. Try and look at it in the volume. But that is, that's right. It's like survival.
Perfect. Yeah, I didn't include that one, but again, the underlying principle being that combination therapy, whereas we used to provide these sequentially, might be beneficial. So these are the drug release profiles from the paste itself, and just showing how we can manipulate characteristics of the paste to change the elution characteristics of the drug over time. And so just to clarify, I didn't mention it before, the final paste is made of a combination of the PLGA and PEG with an additional agent called diblock copolymer, which just aids the dissolution of the paste over time. And by manipulating these variables, you can get more or less release of the drug over time. And so this has been optimized now to release these 3 drugs over a period of a few weeks, resulting in sustained release of these highly synergistic agents. And ideally, this would be localized within the prostate gland itself. And so there's several in vivo experiments that are ongoing right now to test the efficiency of this paste in use. So from the intraprostatic injection point of view, we would like to bring the MR and ultrasound guidance to target a specific lesion and deliver these highly synergistic drugs within the prostate. And an initial feasibility study may be to use the paste as a neoadjuvant role prior to radical prostatectomy, just to understand the changes that occur on a pathologic basis 6 months following injection of the paste. So conclusions then. We're substratifying prostate cancer, introducing quite a few new niches for new treatment modalities, and focal therapy delivered by a multitude of ways have really kind of filled up that space, and somewhat controversial way as well because of the type of disease that they're treating. We know that prostate cancer is multifocal, but without a doubt there is a subset of patients that do have unifocal focus of clinically significant disease on a background of insignificant disease. And this might support a rationale for focal therapy approach in prostate cancer, even in the high volume Gleason 6 state. Focal therapy is attractive, at least to patients, and needs to be properly evaluated. And at one of the recent conferences, Dr. Walsh took the con stand against focal therapy, and one of his conclusion remarks was that it will take more than a negative biopsy at 1 year to convince me that this is effective. And so it speaks to the need for better designed studies to evaluate this in further detail. And the paste might just be a new approach for focal therapy. So it's an exciting space, and thanks you guys for the time.